subscribe now and press the bell icon. Never miss an update.
Welcome to Health Live at Seniors Today. We are delighted to have here with us once again, Dr. Percy Chibber. Dr. Percy Chibber, as the subject of the webinar today, is going to be speaking about prostate care for senior citizens. A little about Dr. Chibber. Dr. Chibber is a senior consultant urologist at the Breach Candy, the Reliance Hospital, as well as he's Director of Urology at the Jaslok Hospital. He has been honorary visiting urological laparoscopy specialist at the Tata Memorial Cancer Centre. And although he's been practicing in all aspects of urology over the last 4 decades, his special interests are endourology, urological laparoscopy, robotic surgery, and renal transplantation. Dr. Chibber took his undergraduate medical education, that is MBBS, in Mumbai at the Nair Hospital. He did his postgraduate degree in general surgery at the same hospital, standing first in the university and was awarded 4 gold medals. He did his specialist training in urology at the University of Edinburgh, Department of Urology at the Western General Hospital in Edinburgh with the well-known Professor G D Chisholm, and also obtained his fellowship at the Royal College, which is the FRCS. He returned to Mumbai and started his urological practice in 1981, but way back in 1981, and was soon appointed honorary assistant professor of urology at the Grand Medical College and the Sir J.J. Group of Hospitals, where he was later to hold the position of professor and head of urology and renal transplantation between 1995 and 2007. Since then, he has been involved with a lot of pioneering work. He was invited by the Cleveland Clinic to spend 6 weeks as an international scholar in the Department of Laparoscopic Urology. Dr. Chibber has been with us in the past. He's written for Seniors Today as well. And we are delighted to have him here once again at for a session today on prostate care. Welcome to Health Live at Seniors Today, Dr. Chibber.
Thanks a lot, Pradyuman. You're going to tell me how to share the screen. I just press share screen. Is that right?
That's right. That's right. How have you been, doctor, since we met? Since we had you on the show 2 years back?
Yeah.
COVID seems to be happening all over again, or some
Yes,
form of.
Seems to be. I mean, I think that COVID is now no longer anything more than just a simple virus. We've got a whole host of viruses making all of us unwell. I mean, there isn't anybody I know who's not down with a bad cough, cold, sore throat, etc., etc. So if we test, I think we'll find a lot of. Have you got the mail? Have you got it?
Firoz, have you got the mail?
Yes, sir. Yes, sir. We are.
So as he comes on, doctor, I have a few questions. Supposing I have somebody, whom I meet who has a cold or cough.
Yeah.
What should I be doing?
The standard thing that you do for any COVID, I think that you should only bother doing a test for RT-PCR for COVID if you have a fever that has persisted for 3 days or more. Then I think you should do a COVID test. Otherwise, you really don't need to do anything. There is an abundance of viruses, all variety of viruses, and they all give you a upper respiratory tract infection. Some of these viruses can be quite serious as COVID can. So, I mean, there is no, I think we have come to a stage where COVID is just one more respiratory syncytial, we call these respiratory syncytial viruses. It's just one more respiratory syncytial virus and can affect us. So you just treat it like any other viral ailment. If it becomes serious enough, you have to contact a doctor. If it's not serious enough, if it 2 days or 3 days, your fever is gone, then you're fine. If you're just a cold, stuffy nose, don't bother about it. Treat it like any other cold. I don't think you should give it any more.
Should one be taking an influenza vaccination now that it's
that's a very moot and debatable point, because influenza vaccines are usually they are designed for the virus of last year. So they're actually outdated. But anyways, they say that if you take the influenza virus, then your attack of flu would be less. But generally, in this country, we don't get killer flus like you do get in the US. You get the flu, does kill a lot of people in the US. Just a simple flu. So I would not be too worried about the flu virus unless you're predisposed to it, like you're diabetic or you have a respiratory problem, you got COPD and things like that. Then yes, maybe you should take a flu virus. But otherwise, no. Okay.
Great. Thank you, Doctor. We have the presentation ready. Over to you, Doctor.
Right. Today we are going to talk about the prostate, and all senior citizens are concerned with the prostate, but some middle-aged people are also concerned with the prostate. You will realize very soon. Next slide, please. Next slide, please. Can I do that? Yeah, okay, fine. Right. So what is the prostate? Can you see my cursor? You can't see my cursor.
We can.
You can. You can see my cursor over the bladder?
That's right. No, not we can't see you for the thing on the bladder because it's not your screen.
Yeah, I know. Okay, sorry. So I can't point out anything. So there you can see the bladder and you can see something called the base. Below the base is this walnut-shaped gland, which is the prostate. And that's between base and apex. That's the prostate. And if you see in the center of it, you see the ejaculatory ducts coming. That's where your semen comes out. And this area, the way it's called base, contracts, and the semen that has come out into the prostatic urethra is ejaculated at the time of ejaculation. Otherwise, the prostate lies very, very patiently in your body doing nothing else. What is the work of the prostate? Next slide, please. Next slide, please. Yeah, so what is the work of the prostate? The prostate provides juices that nourish the sperm. The sperm, once it has been ejaculated, coagulates and forms a coagulum. One presumes one ejaculates into the vagina. And if you do that, it forms a coagulum in the vagina. And then the juices in the prostate, which are there in the semen, will allow that coagulum to release the sperm. The sperms will then travel from the vagina up the birth canal and finally reach the ovum, which is the general purpose of fertility. Next slide, please. And what you see in this slide is, sorry, the previous slide, please, sorry. Now, this slide shows my finger up the backside. You'll wonder why, when you go to a doctor, any surgeon at all, when you go to any surgeon at all, and you have he'll probably put you in a position, in your lateral position and put a finger up your backside. You're wondering why, when you've got a urinary problem, why he's examining your backside. And the reason for that is this, that when I put my finger in the backside, the anterior or the front relationship of the rectum is the prostate. So I put my finger in the backside, I can feel the prostate, the back part of the prostate as shown in this diagram. So that's what I wanted to show you guys. Why is it that we surgeons put fingers in people's backside to examine the prostate? Next slide, please. Right, so this is what shows you what are the functions of the prostate. It is an alkaline fluid that constitutes about 75% of the ejaculate. So remember that the rest of it is 25% is from the seminal vesicles and less than 0.5% is actually the sperms. So the prostate consists of enzymes which allow release of the spermatozoa, and they contain an antigen which is known as PSA. This prostatic juice contains a PSA, and more about that later. Okay, next slide, please. Right, now the common things that we have problems with the prostate are simple benign enlargement, that's the one to the left. That's an enlargement of the prostate that occurs in everybody. Every male who has functioning testes will have an enlargement of the prostate. Why do I say functioning testes? Because you need testosterone for it to develop. For that matter, if in people who don't have testes, such as eunuchs or castrated people, the prostate cannot develop and grow into this enlargement in as age advances. So anybody who has functional testes, the prostate will enlarge after the age of about 55. So it's properly enlarged by the time you are 65. So everybody in the age group of 65 has an enlarged prostate. Some have it more, some have it less, some suffer from it more, some suffer from it less, but everyone has an enlarged prostate. The one in the middle is prostatitis. Now, this is another condition that can occur at all ages, but commonly after middle age. It is caused by an inflammation of the glands in the prostate. Imagine that the prostate has glands. The glands are something like a bunch of grapes. And each grape that we're talking about is where the juice of the prostate is found. When the prostate contracts, when you ejaculate, the juice is squeezed out and comes into the prostatic urethra, as I showed you earlier. If you were not to ejaculate, for example, if you are celibate or if you choose not to ejaculate for a long time, either by masturbation or by ejaculation in sexual activity, then the juices remain in your prostate and they can get inflamed and you can get a prostatitis. It's common after the age of about 35, 40, and it remains common even in older people. It seems to be much more common in diabetics, in whom any kind of infection is more common. So a prostatitis can occur in diabetics. So whenever you have a diabetic who suddenly has, worsening of his prostatic complaints, especially if he has a bit of burning and urgency, going very frequently, if it wasn't there, say about a week ago, then a prostatitis is often the diagnosis that we are likely to entertain. The last one on the right is a cancer of the prostate. Now, this by itself hardly ever gives rise to any symptoms, at least in the early phase. But most of these people have an enlarged prostate from benign enlargement. So they will have symptoms of benign enlargement of the prostate. So there's no specific complaint that a cancer prostate will give you. It just has the same complaints that any old man with an enlarged prostate, I wouldn't say old man, any aging man with an enlarged prostate has. Next slide, please. Thank you. Now let's talk about the most common enlargement of the prostate, that is benign prostatic enlargement. That is enlargement of the prostate that we all get after the age of 55, more likely by the age of 65. Next slide, please. So all aging men have problems with urination. We call those problems LUTS. That's lower urinary tract symptoms. Previously, we used to call them prostatism because we believed that all these symptoms were caused by the prostate. That's not true. They're caused by the bladder and a variety of other conditions. Next slide, please. So what are the problems that aging men get? They either pass urine very frequently, that's frequency. Next. Or they pass urine too soon, that is, before they are ready to pass urine, they have to rush and pass urine, that's urgency. Next. Or they take a long time to start passing urine, that's hesitancy. Next. Or they don't pass enough, that means they leave behind some of the urine that they are passing, and they say, I passed my urine, but again I have to go back. I feel like I want to pass it again. Or they pass it at inconvenient times at night. That's nocturia. Next. Or when they do not want to pass urine, that is after they zipped up their trousers, then they got a little dribbling in their trousers. Next. And they cannot urinate at all. Sometimes you had a long flight, you've had a couple of drinks, and you get off the flight and you suddenly find you can't pass urine at all. That's retention. So these are common problems that old people or aging people can get, and we club all this as prostatism or lower urinary tract symptoms. Next slide, please. Now, what is this cascade of pathology? Let me just point out. On the left is a happy bladder with a normal prostate. there is no problem. On the right is this enlarged prostate, and that's giving you a problem. So next, I can tell you what the problem is. Next, please. There's an obstruction caused by this big laddu of a prostate blocking the outlet. Next. And what that does is that the stream becomes poor. The urinary stream becomes poor because obviously there's a blockage into the outlet. So what does the bladder do? This muscle that you see in the bladder, that's called the detrusor. That muscle contracts more. And as it increases contraction of the detrusor next, it starts getting thicker. Next, please. As it gets thicker, it keeps giving you complaints of frequency. That means you have to go very, very frequently. You'll have to get up at night to pass urine. Next, please. And the bladder gets thick. You see on the right-hand side, the bladder is thick. And as the bladder gets thickened, we have muscles on our body. And if you exercise, the muscles become thick, like your biceps or your pecs. And that looks good and it's functionally better. But when the bladder becomes thick, it's not increasing in function, it actually becomes hypofunctioning. It starts becoming poorer in contractility. Next. And as a result, if it's not contracting adequately, the urine does not come out of the bladder and you get post-void residue. That is, after you pass urine, there's urine left behind in the bladder. Next slide, please. Now, a lot of people come to me, and they tell me, Doc, I have this sonography report and my prostate is 35, and they say it's an enlarged prostate. I said, I'm not interested in the size of your prostate. Oh, my prostate was 35 last year. Now it's become 40. What should I be doing? So the size does not matter. At least as far as your prostate is concerned, size does not matter. For other things, I don't know. So the LUTS are that is the lower urinary tract symptoms, are quite independent of the prostate size. Next slide, please. Next. Digital rectal examination is done to determine not the size of the prostate. I'm not concerned how large your prostate is. I may be concerned only if I'm going to operate and I want to know how much time I'll take to get your prostate out. But I'm more concerned about the smoothness and the texture and the nodularity of your prostate, which might indicate your prostate is not an ordinary prostate and there may be a cancer. So when we put a finger inside, we want to see mainly detection for whether there is a cancer or not. Next slide, please. We do a sonography of the bladder, and KUB is kidney, ureters, and bladder. Why do we do that? Mainly to see two things. Whether you're leaving behind urine after you peed. So whenever we do this USG of KUB, we always do it on a full bladder. Then we ask you to pee, we do it again. We want to see how effective you've been in evacuating your bladder. If you're leaving some urine behind, it shows that your bladder has now started failing, okay? And we also measure the bladder wall thickness, which tells you the same thing, that your bladder has become thicker and it's not better functioning, it's poorly functioning. Of course, we see it for presence of stones and whether the kidneys have got dilated, which is usually very late in the disease of prostate complaints. Next slide, please. So this is a symptom score. We've got these 7 symptoms that we have: incomplete emptying, frequency, intermittency, urgency, weak stream, straining, and nocturia. I covered all those in the early part, and we give it a gradation, and that we give a score to it. That's not important. Next slide, please. Overactive bladder and bladder outlet. As I told you earlier, as the bladder starts getting thicker, in the initial phase, it starts contracting errantly. I don't mean effectively, but errantly, which means it contracts long before your bladder is really full. Next slide. Next slide. So this is an enlargement of the prostate. Next slide. Next slide. Next slide. So enlargement of the prostate can give rise to obstruction. That is, it can give rise to, hyperfunctioning of the bladder. And the hyperfunctioning of the bladder gives rise to this frequency, urgency, and urge incontinence. These are what we call storage symptoms. That means you can't store urine. If you have to pass urine very frequently, you are rushing to the loo. If you are very urgent, you have to again rush, and at night you have to get up. So these are problems that prevent you from storing urine in the usual pattern, which is you are completely oblivious of your bladder for 4 hours or 5 hours also sometimes, and then you pee very comfortably. Next slide, please. And there are other set of symptoms which you call bladder outlet obstruction. These are hesitancy, not being able to start your stream, weak stream, the stream is poorer, straining when you have to get it, and dribbling. So these are two separate symptoms, and we grade them separately, storage and emptying, but both these arise from the enlarged prostate. Next slide, please. Next, please. So when we examine, what do we look at? We say, we first examine you and we play a little drum on your bladder and we say, is your bladder palpable or not? And we examine to see whether you have hernia. One of the commonest causes of hernias, bilateral, is a person who's straining to pass urine all the time. He's been doing that for the last 5 years and he's developed a hernia. We look at the prepuce, that is the foreskin, and the external urethral meatus, because sometimes the meatus is tight and that may be the cause of poor stream. And the prepuce, very important, because this is something which is very, very common nowadays. Diabetics are given a lot of meds that are very, very effective. These meds are called SL2s. They are drugs that help eliminate blood sugar and pass it into the urine. The urine then becomes very sweet or very full of sugar, and sweet urine, which is collecting under the prepuce, causes inflammation with bacteria and fungus, and the prepuce gets inflamed and starts contracting. You will know quite a few diabetics who get problems with their prepuce and will need circumcision at an older age group. One always saw that circumcision was done in young people, but you do circumcision in particular in diabetics because of diabetic inflammation of the prepuce. And last, of course, is a digital rectal examination. That is a very important examination. I told you, we do that to make sure that there is no cancer, is there no suspicion of cancer. And we also do that to see if the patient has got a lot of hard stools in his rectum, because that may be a common cause of urinary problems other than the prostate. Next slide, please. Go ahead. So when a patient comes to us with lower urinary tract symptoms, the first thing we do is to rule out a cancer prostate. As usual, we hope for the best and we are ready for the worst. So always we are thinking of the bad case scenarios first. So we rule out a cancer prostate. Then we check to see if there's any infection and we treat it. And then we see if there's any pathology in the bladder or the kidneys as a result of this prostatic enlargement. Next slide, please. Next, please. Right. Now, when a person has this common old age symptoms of frequency, urgency, and nocturia, and we know that this guy has an enlarged prostate, we first treat him with medication, and generally medication is able to alleviate the symptoms in about 80% of patients, almost 90% if they've come early enough. If they come too late, then obviously these drugs are not likely to work. So what are the drugs that we use? The commonest are a drug called alpha blockers. They are known as either the three common alpha blockers are terazosin, alphazosin, or silodosin, known as Urimax or Silodal or any of these drugs that you commonly are prescribed. Most of your senior citizens will know that your doctor has given you either Urimax or Weltam or something or the other, one of these three drugs. Now, what that does is that the prostate is not an ordinary inert potato. It has small, smooth muscles in it. And these smooth muscles respond to blockage of these alpha receptors and they relax. So your hard potato is replaced by a softer, more amenable potato, and therefore the stream improves. There's another drug which is known as a 5-alpha reductase inhibitor, and these drugs are called dutasteride or finasteride. So often you're given a drug called silodosin and you have silodosin D or Urimax D. The D is dutasteride. What this does, it's a kind of an anti-hormone. The prostate requires testosterone to grow, as we had told you earlier. The prostate requires testosterone to grow. But luckily for us, it's not testosterone, but it's a derivative of testosterone, which we call dihydrotestosterone. And this drug, dutasteride, blocks the dihydrotestosterone without affecting the testosterone, because we can't give you a medication that knocks off your testosterone, then you'll be complaining like hell. So we give you this drug, and all it does, it knocks off the dihydrotestosterone, which is responsible for prostatic growth, and is responsible for your male pattern baldness. Okay, the male pattern baldness is, the kind of hair recession that we get as we age. So we give, if you've gone to your skin specialist and you've got, balding, he will give you dutasteride in low doses, and that helps in getting your, reducing the hair on your widow's peaks. Next slide, please. Next slide, please. There are drugs that we use for the effect on the bladder. As I told you, the bladder is also a very important thing. The bladder overreacts. And if you have a lot of storage symptoms, like you're going too frequently and going too many times at night, then we give you one of these drugs, either mirabegron or solifenacin, and that cools down the bladder. So first we give you an alpha blocker, and if you feel better, fine. But even after, you say, my stream is better, doc, thank you very much, but I'm still getting up 3 times a night. And I still have to rush. I mean, I can't even stay in a meeting because I have to, if I feel like passing, you have to say, sorry, excuse me, guys, and you rush out to go to the washroom, and that's very embarrassing. So then we give you this drug called solifenacin or mirabegron or darifenacin. And what that does, it cools down the bladder, so you don't have to go that frequently. So most of my patients who are enlarged prostate, who come with this lower urinary tract symptoms, most of them get an alpha blocker, and some of them get this dutasteride. And usually we give dutasteride only to people who have large prostates. Any prostate larger than 50 grams is deserving of dutasteride. Anything which is less than 40 grams does not deserve dutasteride. Dutasteride is a medication that has to be taken for a long, long time, and its effect will only be apparent after minimum of taking it for 6 months, and will be more apparent after about 1 year or 2 of taking it. On the other hand, this drug on the top, alpha blockers, that is terazosin, alfuzosin, silodosin, these are drugs that act only for 24 hours. So if you've been given this silodosin, that Silodal or Urimax or whatever other drug, and you've forgotten to take it for that day, you will find that your urine stream has become poorer on that day. It acts only while you take it. So very often patients ask me, how long do I take it? I usually take it till forever, until it stops working, and then I'll unfortunately have to do something surgical about your prostate. Okay, so until it's acting, we continue the medication. Now we come to the drugs like tolterodine, solifenacin. These are drugs given to quieten the bladder, and we give it for some time, say about 1 month or 2 months. And if you're relieved with your symptoms, we say, okay, fine. Now I think we can discontinue them. Next slide, please. Next. Yeah, sorry. Right. Oh, yeah. One more thing. Lots of people who have problems with LUTS, that's lower urinary tract symptoms, also have problems. That's another problem of aging, that erections. Erections may not be good, and they seem to happen. So it's not just, we don't look at only the urinary tract and only how you pee. We also ask all people, there's no reason why senior citizens shouldn't be engaging in good, enjoyable sex. So we ask them if their erections are poor, and if their erections are poor, we give a medication called tadalafil. Now that is a medication that we can give either on demand, that is only when you want to have sex, or regularly. We give a lower dose on a regular basis, and that's a kind of medication I like to give, because tadalafil is a drug. ED or erectile dysfunction is not just a manifestation of aging, it's a manifestation of endothelial dysfunction. It's a dysfunction of all blood vessels everywhere in the body, and unfortunately it manifests first in the penis, so therefore you get erectile dysfunction, and it's not a bad idea to give low dose of tadalafil on a regular basis. Next slide, please. Right, I already told you about the duration of therapy. Alpha blockers till they stop working, and then you need surgery. Next slide. 5-alpha reductase for at least 2 to 3 years. Anti-muscarinic as long as the symptoms persist, and PDE5 inhibitors on demand or continuous use, as I explained to you already. Next slide, please. Now you've been taking these alpha blockers and other medication for the last 2 years or 3 years, and you say, Doc, they were very helpful when I first started them, but now no go. I'm still going very frequently, and my stream is poor, taking a long time. I'm unhappy. Sorry, sir, now you need some surgery. Okay? And what is the form of surgery? What we do at surgery is we remove the prostate, usually through the endoscopic route. It's called that transurethral resection of the prostate. We put an instrument into your bladder through the urethra. It's about the size of an average ballpoint pen. And through that, we have a loop, and the loop cuts through the prostate. The prostate is a vascular organ, so if we just cut without using current, it would bleed. So we use current. There are two kinds of current, monopolar or bipolar. Next slide, please. Sometime when the prostate is very small, we just incise the prostate. We don't have to remove the prostate. Next slide, please. Okay, next slide, please. Right, now these are important things I want to discuss with you. HOLEP, holmium laser nucleation of the prostate. Now there are two lasers that we commonly use. One is a holmium and the other is a green light laser. Now, I would tell you the indications of each of these lasers. First of all, we need to use a laser mandatory if you are on blood thinners and your doctor who's put you on blood thinners says, no way I can stop the blood thinners. This is usually a person who's had a stent put in within the last 1 or 2 years. So before 1 year, no cardiologist will allow your blood thinners to be stopped, because even if you stop the blood thinners for about 7 days, your stent could block up. So in that case, if we need to do any prostatic surgery, we would need to do it with this thing called GLPVP, that is green light vaporization of the prostate. The other thing I told you, you can also use holmium, but holmium is not as effective in preventing bleeding as green light is. The other thing is holmium laser. When do we use holmium laser? We use holmium laser to enucleate the prostate, and that is instead of scooping it out a piece by piece, we actually enucleate the entire prostate, very much the same way as we used to do it, say about 50 years ago, when we used to do open surgery, put a finger and, sort of enucleate the whole prostate and bring it out like a big laddu. That we do using a laser called holmium laser. We do that when the prostate is very, very large. By very, very large, I mean more than 110, 120 grams. We have done prostates which are 250 grams also, which is roughly larger than a tennis ball. Now, for that bigger prostate, scooping out chip by chip would take ages, and that might risk injuring the urethra, because you'll have an instrument in your urethra, that is the pipe in your penis. For too long, it might cause problems. So we prefer not to do any endourethral procedure. We do a holmium laser, or we do a robotic, the last one, robot-assisted simple prostatectomy. So what we do there is we put a robotic instrument and we do the prostate from the above. The same kind of surgery that we did 50 years ago when we used to cut open the patient. Now we just don't cut open the patient. We just put ports inside and remove the entire prostate robotically in the very much the same way as we used to do 30 or 50 years ago. That's only for a very large prostate. Next slide, please. Right. So I've already told you, for a moderate sized gland, TURP is your best bet. For a small fibrotic gland, you say, why small fibrotic glands? As I told you, size does not matter. Even small prostate can give you very severe symptoms. So we might just incise. For a large gland, more than 100 grams, I would say more than 125 grams, we use either HOLEP or robot-assisted simple prostatectomy. So that means, next slide, please. Or open prostate. I wouldn't say that open prostatectomy is dead. If you don't have HOLEP, we don't have robot-assisted, open prostatectomy can be done. Now, if your patient is on antithrombotic therapy, which cannot be omitted, such as stenting, etc., then we use green light vapor prostatectomy. Next slide, please. If the patient is unfit for any kind of anesthesia at all, then we do a prostatic artery embolization. Then what we do is we pass, and there is the radiologist passes a small catheter into the blood vessel that supply the prostate and puts small emboli into it. So the prostate gets embolized and slowly disappears. Okay, next slide, please. So these are the, we have got many other armamentarium, but these are the common ones. Now we come to the most dreaded topic, and that is cancer of the prostate. Next slide, please. I showed you there, this is a normal prostate on the left side, this is a benign prostate in the middle, and the cancer prostate. The cancer prostate arises from the periphery of the gland, as you can see here, what we call the peripheral zone. And therefore, it's very easily amenable to palpation. That's why we put a finger up the backside to feel the prostate. Okay, next slide, please. Right? It usually arises in the peripheral zone, and growth and multiplication of cancer requires androgens. So usually the cancer prostate does not occur in eunuchs or people who do not have functioning testes. Prostate epithelium produces PSA, and this is upregulated in cancer. So we always ask, in addition to putting a finger up the patient's backside, we do a blood test called a PSA. Why? A PSA is a prostate-specific antigen. It's specific to the prostate. There's nothing, no other gland in your body that produces PSA. Therefore, your wife's PSA will be 0 because she doesn't have a prostate. And your PSA will be high if there's any problem in your prostate. If you have an infection, your PSA will be high. If you've got, someone's put needles in your prostate, it'll be high. And if you have a cancer, it'll be high. Next slide, please. So what are the symptoms of cancer prostate? None. The most important symptom is none. They're the same old symptoms that you have because you have an enlarged prostate. You get late symptoms, blood in the urine, pain in the pelvis and ribs, because the prostate cancer has gone to the bones and is giving you pain, or when your kidney function is reduced. All these are symptoms that we dread and don't even want to be aware of. So we should diagnose cancer prostate way before any of these late symptoms occur. Next slide, please. Right, so how do we diagnose a cancer? I already told you two things. We do a digital rectal examination, that's DRE, and that will make us feel any lumps, bumps, or nodularity in your prostate and say, oh, one red flag up, this prostate doesn't look healthy. Then we do a PSA. The normal range of a PSA is between 1 to 4. Now, this is by no way sacrosanct. If you have a large prostate, your PSA could easily be way above that amount. It could be 5, 6, 7, 8, 9, even 10, and you could have a perfectly normal prostate. So we just don't look at only PSA, we look at everything together. But if the PSA is high and your prostate is normal size and you don't have an infection, that's another red flag. So you've got 2 red flags. Then we do a biopsy. Next slide, please. But before we do a biopsy, sorry, wait a minute, I'm sorry, this is an old one, go back. So before we do a biopsy, we've got something else, which unfortunately is not there in the slide. It should have been, I think it's in I've really got this presentation up and ready without too much preparation. So it might have been an older presentation. We have something called an MRI. Increasingly, we use MRI, that's called magnetic resonance imaging. So when we are suspicious that you have a cancer prostate, but not sure, the prostate doesn't feel bad at all, it feels normal, but the PSA is high, and we are saying, should we do a biopsy, should we not? This man may not have any cancer prostate and be unnecessarily putting needles in his prostate. So then we do an MRI. It's known as a multiparametric MRI. And that gives us a very good idea about the internal texture of the prostate. And earmarks, it helps in two ways. It tells us if there's any lesion in the prostate that's suspicious, but it also earmarks where exactly that lesion is. So it helps us to target that lesion in the biopsy. So when we do the biopsy, we give that information to the person who's doing the biopsy, considering it might be the sonographer who's doing the biopsy, and he knows exactly where to target and where to look for the cancer of the prostate. Next slide, please. Now, there is talk about early diagnosis. Is it early diagnosis possible? Yes, it is. Is early diagnosis desirable? Yes, if it is coupled with risk stratification. Now, what do I mean by this? Now, a lot of people will tell you that, oh, come on, nothing to worry about cancer prostate. It's very, very common. And you could have a cancer prostate and you could die with the cancer prostate rather than of it. True and false. Cancer prostates are two different entities. You have a low-grade cancer prostate, which will probably remain low-grade for 10 years. And you're right, it may not kill you. And you have a higher grade prostate, which will kill you very, very short period of time, maybe in a year or 2 years, even 3 years, if you don't do anything. So risk stratification is very important. You can't put your head under the sand and say, oh, cancer prostate are not to be diagnosed. I would say, yes, you must try. I'm not in favor of screening the population at large. I don't think that is beneficial. But if a man comes to me with prostatic complaints, I will always screen him for a cancer of the prostate. If I find he has a cancer prostate, I will biopsy it. And biopsying, I know the kind of prostate he has, and I'll tell him, your cancer prostate is very indolent, it's a very low grade, we're not going to do anything about it. Or it's intermediate risk, we'll watch it, I think we should do something about it. Or it's very high risk, we'll have to hit you with all the guns that we have. Next slide, please. Okay, I think we'll go on to the next slide, because we'll go on to, otherwise we will take too long. Next slide, please. Somebody keep an eye on the time, please. Next slide, please. Yeah. Now, I told you about the PSA. Normally, the PSA is supposed to be less than 4. Okay. If the PSA is less than 4, there's only a 15% chance that you have a cancer. If it's between 4 and 10, it's about a 20% chance you have a cancer. If it's more than 10, you have 50% chance of having a cancer. That's just a statistical percentiles. It is nowhere sacrosanct. None of this is written in stone. Next slide, please.
So we are at 6 o'clock now.
Sorry?
We are at 6 p.m. now.
Yeah. So, okay.
So
fine. Next slide, please. Okay. So I already told you that prostate biopsy is necessary. We have to do it. Next slide, please. Next slide, please. I told you about the MPMR prostate. Now we come to prostatitis. Okay. If the prostate is inflamed, you might get a PSA that goes up, and sudden rise of the PSA. Diabetes mellitus is also a cause for prostatitis, and pus in the urine may indicate prostatitis. Next slide, please. How do we suspect prostatitis? There's a history. When you review prostatic cultures, and you can find out, and you examine the patient, usually his prostate may be tender. What is most important is that unlike there is hardly any pain in the ordinary prostatic complaints. That is the LUTS. They have frequency, they have urgency, but they don't have any pain. You ask them, do you have any pain passing? No, you don't. But when they have pain in passing, discomfort or burning, then suspect prostatitis. Okay, you do a urine culture and they may be negative. You might have to do a urine culture after prostatic massage. And sometimes you may have to do a PSA and repeat it after treatment. Next slide, please. Okay. Go on to the next slide. I won't talk about MPMRI. I don't think you guys are interested too much in that. Next slide, please. Next, please. Okay. How is this prostate biopsy done? It's usually done as an OPD procedure. You don't have to get into hospital. You have to stop your blood thinners for at least 4 days prior to the biopsy. You have to take an antibiotic to prevent any infection. And we have to do a test to see that you're not a bleeder. Then 12 cores are taken by putting needles into your prostate, either from the rectum or from the skin of the perineum. Both procedures are done. Rectum is easier. The perineal biopsies are relatively more difficult, but they are safer because they don't give rise to infection. The prostate biopsies done from the rectum can give rise to infection, not commonly, about 2 to 5%. Next slide, please. Next, please. After you've got the biopsy, why do I need the biopsy? I need the biopsy to give me this thing called the Gleason grade. As I told you, I have to stratify. There's not just a diagnosis. There's no something like, okay, this man has a cancer of the prostate. Yes, no. It's not a yes, no. It's a very detailed diagnosis. So I need to know the grade of the cancer. And I need to classify it as a high-risk cancer, intermediate risk cancer, or a low-risk cancer, because I'm going to treat all these 3 different groups differently. Next slide, please. Next slide, please. I won't bother with all these things. Okay. Now, when you diagnose a cancer prostate and you've seen the grade, and now you're going to decide whether the cancer has left the prostate and gone anywhere else. It commonly goes to the lymph nodes and can also go to the bones. About 15 years ago, we used to do 2 tests. We used to do a CT scan to look at the lymph nodes and a bone scan to look at the bones. Now, we don't do that anymore. We do a simple one-stop shop test called a PSMA PET-CT. That's a PET scan done with PSMA marker, and that will tell us whether the nodes are positive, whether the bones are positive, or there's any soft tissue, such as liver, lung, whatever. So it's a very good test that shows us whether the cancer has left the prostate, which is the origin gland where the cancer was, and gone anywhere else. Why do we need to know that? Obviously, if it's left the prostate, there's no point treating the prostate anymore. You have to treat it systemically. Means you have to do something that will affect the cancer cells wherever they are. But if it is contained in the prostate, and if the grade is amenable, then you should do something to the prostate directly. Next slide, please. Right. So are all prostate cancers created equal? No, they're not. You have to do risk stratification. Next slide, please. Next slide, please. Next slide, please. We're running short of time, therefore I'm just going through all this. Right. If the cancer is relatively low grade, or what we call favorable prognosis, then you can treat with curative intent. That means you are telling the patient, I think I can cure you. That means the cancer is limited to the prostate and the grade is what we call a low risk or intermediate risk. Then what we do is either we remove the entire prostate, which is known as a radical prostatectomy, and we remove the nodes on both sides prophylactically, more for the grading than, because if the nodes turn out to be positive, I'll probably add something to the treatment. If the nodes are negative, and if the cancer remains the same kind of thing that was there on the biopsy, then I don't give any more treatment. I say, gentlemen, I think you are cured, but we'll keep an eye on you. The other thing we can do with curative intent is radiation. That is external beam radiation. I generally prefer radiation only for people who cannot undergo surgery for reasons such as old age or morbidity from other causes such as cardiac conditions, etc., etc. Okay. What is the advantage of radiation? That you don't have to do surgery. It was at one time preferred because surgery was a very, very complex situation and was very often involved with blood transfusion and staying in hospital for a longer period of time and incontinence for a long period of time and all other complications. Today, it's not that. You stay in hospital for no more than 3 days. Continence usually comes back in about 3 months, but in many, many cases in 3 weeks' time, depending on the grade of your prostate. And so it's quite a win-win situation. So I would err on the side of removal of the prostate rather than radiation. The other thing is once the prostate has been removed, and if something were to come back in that area, you can always go to radiation to radiate the bed. But once you've given radiation, you can't go and remove the prostate, not without significant morbidity. So if you've done a radiation and now the cancer has come back again in the prostate because you're not removing the prostate, it's still there. So the PSA is going up and now you do biopsy and say, sorry, the cancer has come back. Now, doc, go and remove my prostate. I say, I can do it if you want me to, but it's not going to have the same prognosis because it's everything going to be stuck up because of the radiation and the prognosis will not be so good. You might be incontinent for a longer period of time. Next slide, please. So how do you do surgery for the prostate? There are 3 ways. Open surgery is now almost throughout the world and in this country are obsolete. We don't do open surgery for cancer prostate at all. Why? Not because we have a robot now. It's because open surgery was exceedingly difficult because the prostate is a gland which is stuck in a very obscure corner of the pelvis. The pelvis has a front bone called the pubic bone. That's a bone that you feel just above your penis. And it's lying way behind the pubic bone. So if you cut the tummy and you look inside, it's lying behind the pubic bone. You can't reach it with your instruments. So you need bent instruments to get there and to operate on it. After you've removed the prostate, now the urethra, that is the tube from the prostate onwards, has receded still further down. So to suture the bladder to the urethra becomes nightmarishly difficult because of the difficulty. Also, bleeding can occur right throughout. It is not common at open surgery to transfuse 1 or 2 pints of blood. With robotic surgery, what we do is, a robotic surgery is essentially laparoscopy, which has been modified by better instrumentation. So we call it robot-assisted laparoscopic surgery. It is laparoscopy, but the instruments are better, the vision is better, and the magnification is better. So that's why we call it robotic surgery. What we do is we put next slide, please. I just give you the advantages of robotic surgery, and then I'll show you what it is. It has 3D imaging. So the imaging is like you see in your 3D movies. It's stereoscopic 3D. So I have good depth perception, which you don't get at laparoscopy. It magnifies the view 10 times. So even a small blood vessel, which is about the size of an average string, looks to me like a little cord, okay? The instruments that I put in are wristed, W-R-I-S-T-E-D, wristed, kalai. So, or whatever you call a wrist. So they are capable of 6 degrees of freedom, like my wrist is. I can move my wrist in 6 different degrees of freedom. And that's why you can, the other thing about the robot is completely steady. If I remove my head from the console, the instruments do not move, not even a fraction of a millimeter, okay? The movements are scalable and far more effective, than hands-on. It's easy to train people on this. Next slide, please. Next slide, please. Okay. This will give you an idea of what the robot is. Now you can see it has 3 components. One is the console. That's right in the front where you see this gentleman sitting down with his head tucked into it. That's the Viewmaster which you see there. And he's looking at it. He's not washed up. He's not scrubbed. He's not wearing any protective. But the patient is lying remote, is lying away from him. And the people on the bedside are scrubbed. Okay, there are ports inside. And there's this huge machine. And it's got the ports inside. And he's manipulating this with the joysticks. And it's remotely affecting the instruments to move inside the body. Okay, so it's got a surgical cart and a video cart. Next slide, please. Next slide, please. So that's the console. This is where the surgeon sits down. He's got a nice place to rest his hands. He puts his head in here, and you can see those. Next slide, please. Next slide, please. So you see that here I am sitting down. I'm not scrubbed. My head is in the console, and I'm very comfortable. I can sit in that position and operate for 2 hours, 3 hours, 4 hours, 5 hours without getting too fatigued. Next slide, please. This is the hand control. There, I'm using a robotic control. Any movement on my wrist, turning, movement forward, backwards are all translated into this. Can you see this thing? The instruments, they are wristed. They can move in any direction. Next slide, please. There, next slide, please. There, you see, the instruments are wristed, like my wrist. Next slide, please. This is a gentleman called Endourology who did a lot of work on the, and he was one of my teachers in USC. Next slide, please. So next slide, please. This is a Reliance, so it's showing you the Reliance robot, okay? Now, when we do a, operation for cancer prostate, we look at 3 different modalities. We see how effective is the cancer control, how good is the continence of urine, and how good is your sexual function. Next slide, please. After, I'm sorry, I don't think we need to go. This is more for surgical people. Next slide, please. Next, please. Yeah. For those who are already beyond the process, what can we do? I mean, those people who have already got metastasis, what can we do? I told you earlier that the prostate grows because of androgens from your testes, what we call testosterone. So if you remove the testosterone from the body, then the prostate cancer, wherever it is, whether in the prostate or in the nodes or in the bones or wherever they've gone, will start shrinking. So you can do that in 2 ways. One, you can remove the testes surgically, which is known as a bilateral orchiectomy, or you can give a drug called an LHRH analog, which causes the same effect. It's called medical castration. Essentially, it is castration, which means removal of all testosterone from the body. Okay, next slide, please. Next, please. Okay. Fine. So we can either of these things, we then check whether the patient is in castrate level. That means his testosterone is very low. And then we keep on checking the PSA. Next slide, please. Fine. I don't think we need to go this. There are many more for people who have been given this medication and the cancer has come back again. There are numerous other newer medications. We can keep on treating them. We have patients who have been presented to us with widespread metastasis all over the body, and they're still alive 10, 12, 15 years after their diagnosis. I've recently got a patient who 15 years after his initial diagnosis of widespread metastasis, and he's still alive 15 years later. So we've got multiple treatment modalities available. Sorry, I might have exceeded my time. Pradyuman, please forgive me.
Thank you very much, Doctor. It was an amazing presentation and so very detailed. We have quite a few questions that have come in, Doctor. We are right now at 6:11. And
is there a commitment on your time, or is it something, or what? I don't know. I'm quite happy to answer as long as it's required. But I guess in the Zoom.
No. There's no problem about the Zoom time. It's just that we we normally finish by 5:45.
I know.
That's all right. But the presentation was very good, and I think most of the answers
Questions have been answered, I
have
guess.
been answered. But I have a few questions that have come in, which I'll just
Please.
one is from Mr. Sudhir Srivastav. He says,
Yes.
does having an active sex life reduce the chances of an enlarged prostate?
No, an active sex life would reduce the chance of prostatitis. Yes, that is true. If you are ejaculating regularly, whether it is into someone or it is with the use of your hands, it's all the same. Ejaculation on a regular interval is important to prevent prostatitis because that empties the prostate and prevents stagnation and prostatitis. Does prostatitis give rise to cancer prostate? Not proven at all. So I'm sorry, I can't give you an answer about active sex life and cancer prostate. No relation. But go ahead.
There's
Be
a question
active.
from Nair, who's 71, who says, what precautions should senior citizens have to avoid urine-related diseases? I think you've answered most of them, but
I can tell you only one thing, Pradyuman. There are only one preventable, one non-preventable cause of cancer prostate, and for that matter, many other cancers. One is genetic. You can't prevent that. So what if you have a genetic predisposition to a cancer prostate? So therefore, we ask patients always, did your father or any of your uncles have cancer prostate? And if his father or uncles have had, then we start screening earlier. We start screening as early as 45 and 50 for a cancer prostate. That's one thing. In other places, then if you are a Black American, you're of African origin, cancer prostate is very much more prevalent in the Black races. Other than that, so that's a genetic predilection. The second thing that can give rise to all cancers is obesity and insulin resistance. If you are obese, if you're insulin resistant, then your chances of having any cancer and prostate cancer are a bit higher. Okay, so those two are the only one preventable, one non-preventable cause of cancer prostate. Can you take anything to prevent cancer? No, nothing at all. Just healthy diet, a lot of fruits and vegetables, a lot of cruciferous vegetables, and a healthy diet. Multivitamins if you feel that you need them.
Mr. S.K. Puri asks, are there some people say that to avoid dairy products? Are there any other dietary restrictions?
Dairy products are now very much in the, I don't think there's any proof one way or another. I mean, the vegan lobby does want to discourage you from using dairy. And I really don't think that there's anything in dairy that is directly linked to cancer prostate. No, nothing at all. Neither is there in meat, neither vegetarian. I mean, I'm not saying that a vegan diet is not a healthy diet. It's a very healthy diet. If you can maintain it, certainly a vegan diet is a very healthy diet. I wouldn't say vegan, I would say a whole food, plant-based diet. Whole food, plant-based diet. That means no preservatives, fresh foods, nothing that comes out of packages is a healthy diet. Because I think it's not meat and dairy that is dangerous, but it's how we treat meat and dairy. Milk contains estrogens because cows are given estrogen. Meat contains, milk contains estrogens and hormones. Meat contains antibiotics because a lot of the poultry are given antibiotics and a variety of other things. So it's contamination of meat and fish and dairy that is worrisome, not inherently the product.
Doctor, there are quite a few questions that have come in. I'm going to
find out
offline and request you for coming with us once again on this.
Yeah, and you request me to remind me next time a few days in advance. I'm sorry, I'm exceedingly forgetful. I've got so much on my calendar that I can forget.
Absolutely.
And it's very, very fortuitous that you caught me at a time when I could come. I was in theater. I was in theater just about
I
15 minutes before your phone call.
Doctor, quite a few questions have come in. I'll just take two because there's one which seems to be a little complex, but still. This is Mr. Sudhir Srivastava.
Again, yeah.
Who's
Hi, Mr. Srivastava. Tell me.
64. He is
Yes.
male, hypertensive, hypothyroidism, heart disease on medical management, underwent surgery in Jan 2023 for removal of venous cysts in both kidneys. Prostate megaly with intravesical protrusion on Welton 0.2. X-ray KUB is normal study. Post-void retention is nil. Other than medication, any alternate treatment for enlarged prostate, he asks. Some renal cysts still remain. Other than surgery, any other way to remove the renal cysts?
Nothing. We don't normally remove renal cysts. If they are removed, there must have been some cause and worry. That means they were complex renal cysts. If they are complex renal cysts, yes, there is a cause for worry because that is a worrisome kind of cyst. But I mean, that's entirely your doctor would have told you that. As far as your prostate is concerned, if Weltam is doing you good, how would you know how good it is? Do your flow rate. If you're pissing at a good flow, then you're okay, continue Weltam endlessly. There's just one worry about intravesical protrusion. That is a prostate that's protruding into your bladder. These Weltam and other alpha blockers don't seem to work too well when there's a significant protrusion in the bladder, significant. But if it's working, if your Weltam is making you pee better, as proven on a good flow rate. A flow rate is the simplest test ever. Just go to your urologist and he has a small little machine, piss into that machine, and he will give you a chart that shows what is the speed of your urine flow. And that's a good indicator that everything is all right. Does that answer your question, sir?
I guess it does answer his question, but thank you very much, Doctor, for this session. For those of you who have asked questions, we have saved your questions when we request Doctor to come the next time, and I will.
Before I depart, let me once again, from the bottom of my heart, apologize for this. What should I say? For this cock up. Okay, right. Thanks.
No problem. Thank you very much, Doctor, for being here. And to all of you here, we have saved your questions. When we invite Dr. Chibber once again, we will pose these questions to him and we will have a, but the presentation was so good and so detailed that I think most of your questions which you had asked before the presentation were made would have been answered. Thank you very much once again, Dr. Chibber, for being here. And to all of you who have registered and attended this session, and those of you who are watching on our other platforms, thank you very much. We will be back once again next Saturday at 5 p.m. for another session of Health Live at Seniors Today. Thank you, Dr. Chibber.
Thanks, seniors. Thanks, Pradyuman. Okay, take care. Bye.
Subscribe now and press the bell icon. Never miss an update.